Not any interpretation of ABG. This is purely interactive session with clinical applications. ABG classes you may have listened so many times where there are so many formulas, everything is memorized. I am not doing anything memorization here. Whatever I remember, the way I am telling you. So ABG itself is a misnomer. Why ABG? Why not VBG? Why only we require arterial blood sample? What is the difference between arterial blood sample and venous blood sample? Why only arterial blood sample is required? And in which cases? In which cases arterial blood sample is required? In those patients you can get SpO2. SpO2 refers to PaO2. Patient doesn't have any shock. What is the role of ABG here? There? Arterial blood sample in a patient with say, in your perspective it is called critical limb ischemia. It's not diabetic foot or something, some foot problem is there, foot ulcer is there, but the problem is critical limb ischemia. Because of any reason, because of peripheral arterial disease, because of embolism, maybe of some other reason, there is some critical limb ischemia is there. There, why do you require ABG? Saturation is fine, no lung problem, no COPD, no ILD, no pulmonary embolism. Why? Why do you require ABG there? Not required. ABG is not required in all the cases. Most of the cases where you are suspecting metabolic problem, where metabolic origin you are suspecting, can be ketoacidosis, can be ethanol, can be toxins. In all those cases, there is no requirement of ABG. VBG is enough. But there are some differences between ABG and VBG. So we have to know that what kind of differences are there. This equation we have been studying since our intermediate classes. Carbonic anhydrase enzyme, CO2 plus H2 is equal to H2CO3, reversible equation, followed by reversible equation H plus plus HCO3 minus. So this CO2 will be high in VBG compared to ABG. I am comparing with the same patient, same situation. CO2 will be mildly higher. How much higher? It will be around 5 to 8, not more than that. So when CO2 is high, obviously forward reaction will be triggered. H2CO3 will be high. So venous sample will be acidic. Compared to VBG, venous sample is acidic. How much acidic? If 7.4 pH is normal for ABG, 7.35 is normal for VBG. So 0.05 variation is enough. When this equation is triggered, when this concentration is higher, obviously this forward equation will be triggered. So H plus will be high, leading to acidic sample, and bicarbonate will be high. So VBG thing is, what we require is metabolic. If you are looking for metabolic component in a case of VBG, bicarbonate will be high in VBG. Compared to ABG, bicarbonate will be high by around 5 milliequivalents, approximately 3 to 5. So if you are comparing VBG, there is according to Sigurd-Andersen equation, bicarb base excess will be there. The definition of base excess is the amount of acid we have to add to bring the pH to 7.4. So when the bicarb is higher, so we require less base to bring the pH to 7.4. So base excess will be relatively negative. Means it's on lower side compared to ABG. Bicarbonate base excess will be relatively negative in VBG sample. So all these equations are we don't have to remember, these are basic equations. So when bicarbonate is higher, we require less base to bring the pH to normal. So base excess will be somewhat lower, negative comparatively. So next, acidosis or alkalosis, whatever it may be. There are many mechanisms happening in the body. Every time it will be happening. It can cause acidemia, it can be cause alkalemia. Finally, the output is, final result is acidosis, can be alkalosis. So patient may be having at the same time high anion gap, normal anion gap, respiratory acidosis. Can be having same time acidosis, alkalosis at the same time. So finally, ultimately we will look at pH. If the pH, arterial pH is less than 7.4, it is acidosis. Arterial pH more than 7.4, it is alkalosis. We will see what are metabolic component or respiratory component, we will check it once. Acidosis can be happen via two reasons. There can be loss of base from the body, or else there can be addition of acid. What kind of acid? Can be non-volatile acid. Even bicarb is also acid. This carbonic acid is also acid. This carbonic acid is a part of carbonic buffer system. So we don't consider this as, it's a weak acid. It's not a strong acid. Whatever the ions that are coming out, this dissociation is not complete. This is relative dissociation only. This is not complete dissociation. So whenever the additional acid, inorganic acid or organic acids are added, it will cause acidosis. Whenever there is loss of base from the body also, it will cause acidosis. So what is the difference? How can we check that? Whether there is loss of the base or else it is addition of the acid, or both can happen same time. Both can happen same time. The patient is vomiting. There is loss of acid from the body, HCl. The patient is, we are doing RT suctioning, NG suction. There is loss of acid. The patient is passing acidic urine. There is loss of acid. The passing basic urine, alkaline urine, renal tubular acidosis, type 1. Renal tubular acidosis type 2. There is loss of bicarb from the body. Urine pH is mildly higher. There is loss of base. So how do you differentiate? Once the patient is having acidosis, patient can be having acidosis by having addition of excess acid or else loss of existing base from the body. How do we differentiate that? Whenever an additional acid is being added to the system, it will consume the base. We are adding some acid, some form of acid we are adding, or else some form of acid that is being produced which has to be excreted normally because of some organ damage, some end organ damage, it is not being excreted normally. So acid levels are being picked up. Acid levels are high. Example, lactates. Lactates are produced normally. Once the liver and kidney are normal, they have to be excreted. But acid, because of ACLF or else ALF or else CLD, these lactates are being accumulated. So this is this is kind of additional acid. So obviously there will be anion gap will be elevated. This additional acid will be dissociated into anions. Lactic acid will be converted to lactate plus H plus. This lactate is a form of anion minus. So obviously whenever an additional acid is being added, anion gap increases. So cult, mud piles, so many mnemonics are there, I don't remember, and I recommend not to remember everything. So whenever an additional acid is being added, anion gap will be increased. Whenever body is losing base, anion gap will be normal. Base can be, loss of base happens from two kinds, can be through urine, can be through gut. So whenever it is being lost through gut, it will be exchanged by chloride. So hyperchloremia will be there. Hyperchloremic acidosis will be there. Whenever it is being passed through, lost through kidney, renal tubular acidosis, there is no exchange. There is no exchange. That happens because of many things will be. Aldosterone resistance will be there. Can be a Gentleman problem, can be Bartter syndrome. There are so many things. We will come to that. We generally add, no-dosage tablets, eplerenone, spironolactone, Dimox. So where do we add Ditor plus? Common thing, common drug in ICU, OP, anywhere. Along with Ditor, what is the need of plus? Spironolactone. Or else along with the Ditor or Lasix, what is the need of Planep? Or else Dimox we are using for inacute fluid retention. Or else Dimox we are using in raised ICP cases for excretion of fluid. What side effects does it have? Hypokalemia. Dimox causes, first of all, Dimox is carbonic anhydrase inhibitor. So it will inhibit in kidney. Carbonic anhydrase inhibitor in PCT, proximal convoluted tubule. So there will be loss of bicarb. So it will cause metabolic acidosis. First thing. So what is the role of Planep or else spironolactone? Generally in CLD cases, nephrotic syndrome cases, in acute decompensated heart failure cases, we will add Planep commonly. Prevents hypokalemia. Hypokalemia is due to Lasix. Apart from that, there is primary indication. We can use supplements also for that. So to prevent hypokalemia, we can use supplements. But there is something else we have to add because of that. Whenever there is third spacing, or else say a patient admitted with hypertensive crisis, known case of atherosclerotic disease, a patient was found to have renal artery stenosis. When we give telmisartan to that patient, creatinine rise up by 40%, 50%. Contraindication. So what is the role of Planep in, say, EF less than 40%, EF less than 50%, or else patient with CLD with ascites, third spacing, patient with hypoalbuminemia, severe hypoalbuminemia with generalized anasarca. So why do we add Planep there? What is the role of Planep? So in general, a patient came with EF less than 40% with shortness of breath, with mild bilateral pedal edema. There is no third spacing, means there is no pleural effusion, there is no pericardial effusion, there is no ascites. Mild congestive changes are there. European Society of Cardiology recommends Planep or else mineralocorticoid receptor antagonist when EF is less than 40%. So what is the role of that? Why do we add any mineralocorticoid when there is a Lasix is there? Primary in place is loop diuretics is there. Either Lasix or diet or is there. Our main goal is to reduce fluid in the system. Reduce fluid in the system through diuresis. We are doing that. What is the role of addition of another diuretic? Say potassium sparing diuretic. What is the role of addition of another diuretic to the system? When there is already loss of fluid we are getting through primary loop diuretics or else thiazide diuretics, why do we need to add another diuretic? Whenever there is EF is less than 40 or else third spacing, what kidney senses there is reduction in intravascular space. So kidneys will produce renin. This renin will activate RAS, renin angiotensin aldosterone system. So there will be excessive reabsorption of free water. So we can reduce free water, but we have to reduce the absorption of free water also. We can remove the free water. All these patients generally present with mild hyponatremia. We don't have to correct mild hyponatremia in a patient with ADHF, decompensated heart failure or else CLD. If we give sodium in these patients, ascites will further increase. If we give sodium in these patients, shortness of breath will further increase. So to prevent that, we will add Planem. So what kind of, initially on presentation, what kind of metabolic disorder we will anticipate? Whenever there is a hyperaldosteronism, that is secondary hyperaldosteronism, there will be metabolic alkalosis will be there. Because this aldosterone acts on kidney, this aldosterone absorbs sodium along with this water and excretes potassium along with H+. So there will be metabolic alkalosis. So metabolic alkalosis we anticipate. To prevent that metabolic alkalosis, we can give mineralocorticoid antagonist. So, but some patient already admitted in ICU and the patient is on already Lasix. Lasix infusion or some dose of Lasix is there. Patient developed metabolic alkalosis then. Is there any role of spironolactone there? Initially on admission, patient doesn't have any metabolic alkalosis. Metabolic acidosis was there. Patient, say assume patient admitted with myocardial infarction, inferior posterior wall myocardial infarction with increased lactates, metabolic acidosis was there. On admission, we are giving Lasix because the patient have grade 3 pulmonary edema. So we started on Lasix infusion. Patient developed metabolic alkalosis. Along with metabolic acidosis is there still. We will talk about metabolic acidosis later. In this case, metabolic alkalosis is there. Metabolic alkalosis can be stop Lasix. Do we have to add this mineralocorticoid receptor antagonist, or else do we have to add something? The metabolic acidosis part can be due to lactates because there is decreased contractility. Patient relative deficiency of oxygen is there. I would say there is relative deficiency of oxygen, which is causing lactatemia. So for the lactates to decrease, we can add inotropic agent, dobutamine or else milrinone. But to prevent metabolic alkalosis, spironolactone. Spironolactone has two effects here, or else Planem. It will add to diuresis, it will prevent hypokalemia, it will prevent metabolic alkalosis. So the patient is developing metabolic alkalosis already on Lasix infusion. We have to stop infusion. We have to reduce the dose of Lasix. Is this saline response to metabolic alkalosis? We will come to that. Once we have to check the urine chloride then. If the urine chloride is less than 20, maybe we can give fluid in that patient. Apart from fluid responsive, all these patients will have IVC dilated, all these patients will have low EF. We can't depend on these also. IVC is a dynamic, static thing. IVC will vary with ventilation, IVC will vary with respiratory pattern. So there are so many things. Already effusions are there. We can't remove effusions significantly, more than 1 liter a day. We can't remove it. So effusions also, it will take some time. So in these cases, the patient is developing metabolic alkalosis. It implies that we are over-diuresing the patient. So we have to stop the Lasix, or else we have to decrease the Lasix. So coming to metabolic acidosis, there is generally one mnemonic is there, cult is there, but no need to remember all these things. Previously, people used to say mud piles. Now they used to say cult. So patient admitted with some form of metabolic acidosis, high anion gap, ABG. Patient admitted with respiratory distress, lung is completely fine, chest X-ray is completely fine, but we have seen what metabolic acidosis is there with a high anion gap. Maybe some other cause is causing metabolic acidosis. So metabolic, can we give soda bicarb in that patient? Whatever, most of the cases in ABG, the ultimate goal is to give soda bicarb or not to give soda bicarb. General thinking is that. General thinking is ABG is equal to plus or minus soda bicarb in ER. So patient admitted with high anion gap acidosis, where we can give soda bicarb, where we can't give soda bicarb. Patient already having sodium overload. Maybe he might have relative hyponatremia, but total body sodium is on higher side. And we are giving from outside sodium bicarbonate. Bicarbonate is a buffer. Sodium will rise. Sodium is strong ion. Bicarbonate is not strong ion. Bicarbonate is a buffer system. The sodium will rise, further adding to fluid overload. Patient with severe EF less than 25%, or else severe ALF, ACLF, acute and chronic liver with refractory ascites. Can we give soda bicarb? Because of increased lactates. The primary thing is increased lactates, or else maybe because of CKD patient in grade 5 CKD. Uremia is completely different. All these three things are different. This thing is different. Uremia can have both high anion gap and normal anion gap. When it will have high anion gap, when it will have normal anion gap. Anion gap refers to unmeasured anions minus unmeasured cations. These unmeasured cations, unmeasured anions includes phosphates and sulfates. So whenever there is CKD, patient will have metabolic acidosis because of various reasons: hypoproteinemia, hypoalbuminemia, anemia. Increased lactates will be there because of reduced excretion. So many things. But when uremic patient will have high anion gap, when the uremic patient will have normal anion gap. Ultimately, when we can give soda bicarb nodosis tablet, when we have to give IV sodium bicarbonate, or when we can give K-bind sachet, when we can give potassium binders, when we can give phosphate binders. Where is the role of phosphate binders in CKD? When is the role of phosphate binders? So whenever this unmeasured anions increases, high anion gap increase. So GFR, estimated GFR less than 20 in generally, means grade 4 and 5. Patient used to have high anion gap. Grade 1, grade 2, grade 3 patient will be having normal anion gap only. So whenever there is normal anion gap, we can give nodosis. There is no role of nodosis in AK. If there is AK, only IV, if necessary only. That too, if necessary only. Whenever there is chronic, means more than 90 days, then only we can give nodosis. Because nodosis also adds to sodium. It will also further increase fluid overload. Only thing is there is loss of bicarbonate. The problem in CKD is there is loss of bicarbonate. There is failure of kidney to regenerate bicarbonate. That's why we can give soda bicarb, nodosis tablet. Not in AK. There is no role in AK. AK is some other mechanism, maybe toxins, maybe some other infection, maybe nephritis, some other thing, maybe drug induced, that is causing AK. We have to prevent that insulting part. We have to remove the insulting part only. We can't give soda bicarb or nodosis from outside. So whenever there is unmeasured anions increases, mainly sulfates and phosphates. Whenever sulfates and phosphates are increased, then only high anion gap will be there in CKD. Otherwise, no high anion gap in CKD. Remaining all these things, ketones, lactates, toxins, all these things are nothing but, ketone is nothing but acid. Ketone is nothing but beta hydroxybutyrate, acetate, all these are acids. Lactate is acid. Toxins mean ethanol, methanol. Methanol converts to formic acid. Similarly, ethylene glycol, glycolic acid. All these are acids. So we are adding to a system, additional. All these causes high anion gap. High anion gap acidosis is always external acid is being added. No role of soda bicarb. No role of soda bicarb. Unless pH is less than 7 or 6.9. The patient is hemodynamically unstable, we may give. The patient is hemodynamically unstable, cardiac contractility is very less. Then maybe 50 milliequivalents to 100 milliequivalents we may give. Beyond that, there is no role of soda bicarb in high anion gap metabolic acidosis. So the primary thing here is ketones. Ketones can be due to starvation, ketones can be due to alcohol, ketones can be due to uncontrolled diabetes with relative or also absolute insulin deficiency. What is the difference? How to find the difference? Ketones may be trace, ketones may be 1+, ketones may be 2+, ketones may be 3+. Sometimes immediately if the patient comes early, there is no ketones positive. Ketones, blood ketones we are not checking here. Serum ketones we are not checking here. So we can't depend on urine ketones for treatment of diabetic ketoacidosis. So the primary thing is either we have to give insulin with potassium, plus or minus potassium, depends on levels. That is a different topic completely. The primary thing is to reduce ketones production, we have to give either insulin with fluids. If the patient is having alcoholic ketoacidosis differs from diabetic ketoacidosis completely. Alcohol metabolism is completely different. Alcohol metabolism leads to increased NADPH. Increased NADPH reduces gluconeogenesis. They may go into delayed hypoglycemia. So we have to give dextrose. Thymine maybe they are having thymine and acetyl coenzyme, Krebs cycle pyruvate dehydrogenase will be there. Pyruvate dehydrogenase cofactor is thymine. So we have to supplement thymine provided the patient is having deficient chronic alcoholic, not in acute alcoholism. If the patient is known case of chronic alcoholic, then we may give thiamine. Apart from that, starvation, metabolic acidosis won't be that much severe. First of all, VBG pH will be bicarbonate will not be less than 15. Bicarbonate will be around 18 to 17. Only thing is we can use supplements, dextrose supplement with IV fluids. That's it. Uremia, we have talked about uremia. Lactates. So lactates, also two kinds of lactic acidosis is there, type A, type B. And type B, there are different things. Type C is also there, which is unnecessary. No. Type A is completely due to relative deficiency of oxygen. Can be patient is having oxygen deficiency. Can be patient is having lack of oxygen to a part, especially say myocardial infarction, critical limb ischemia, gut ischemia, whatever it may be. There we can give, there is no role of bicarb, lactic acidosis. The primary culprit is, can be pulmonary embolism, can be MI, can be gut ischemia, can be limb ischemia. We have to treat that apart. Either it should be thrombolysis, it should be PCI, that thing. Toxins. So all these, generally ABG we think about MAPS. Methanol, ethanol, polyethylene glycol. Methanol converts to formate. So formate is an anion, a high anion gap is there. Ethanol completely different. Polyethylene glycol, glycolic acid, glycolate, high anion gap. So the thing is, either we have to go for hemodialysis, or else some of the drug is there, fomepizole is there. Fomepizole. Or else we have to treat these patients with dialysis. There is no other go. Only thing, how can we differentiate from this? In salicylate also causes high anion gap. Here we can check urine osmolality. Urine osmolality more than 10, think of these three. Methanol, polyethylene glycol. Urine osmolality less than 10, think of salicylates. Salicylates, another clue is salicylates also increases respiratory effort. It will stimulate respiratory center. So metabolic alkalosis will be there, respiratory alkalosis will be there in salicylate poisoning. These are cerebral depressants. So PCO2 will be higher. This is respiratory center activator. So PCO2 will be lower. We can differentiate from these two. So coming to normal anion gap acidosis, normal anion gap also, whenever there is loss of bicarbonate through gut will absorb chloride from the gastric secretions. So chloride will be higher, bicarbonate is lost. So hyperchloremic, whenever bicarbonate is lost, it is metabolic acidosis. So but this minus will be covered by chloride, Cl minus. The Cl minus will hyperchloremic metabolic acidosis. Sometimes because of in some surgeries they may connect ureter to sigmoid colon, ureterosigmoidostomy. Here also sodium and chloride will be lost through gut. So gut will absorb chloride and gut will in exchange for bicarb. So patients develop metabolic acidosis. So ureterosigmoidostomy, it is clearly from history. It is clear from history, we can get that patient is having ureterosigmoidostomy. All these till stomach, the acidic environment is there. To cover the acidic environment in the gut, intestinal secretions and pancreatic secretions are full of bicarb. Whenever there is pancreatic fistula is there, bicarb is lost through gut. So pancreatic fistula, normal anion gap. Diarrhea, normal anion gap. Carbonic anhydrase inhibitors, normal anion gap, because that will cause loss of bicarbonate through kidney. There is no correction at all. Body won't compensate to minimal extent to bring the pH to normal, near normal, not normal, or else there is no concept of overcompensation. There can be multiple mechanisms causing acidosis, alkalosis. But compensation will be near normal, not completely, or else not overcompensation. So I don't remember all these compensatory formulas. I don't remember. I am saying whatever I am practicing. Metabolic alkalosis. Generally, we have talked about metabolic alkalosis. Mostly, we can give fluid, or else we can't give fluid. Two types: saline responsive, saline resistant. Saline responsive, we talked about. Patient is vomiting. There is obviously there is loss of fluid is there. So we can give fluid. We can give NS. Ideal fluid of choice is NS. When there is NG suction, there is loss of acid. So to prevent that, we can give PPAs. Next thing, when there is a loss of either loss of acid is there. When there is loss of fluid is there, obviously we can give fluid. Saline responsive. How can we tell that? Urine chloride is less than 20. If urine chloride is more than 20, that is responsive. Hypokalemia will cause metabolic acidosis, metabolic alkalosis, because hypokalemia H plus and K plus, they can move freely through cell membrane. So whenever there is hypokalemia, some part of potassium from intracellular potassium will come out and some part of H plus, extracellular H plus will go inside. So hypokalemia also causes metabolic alkalosis. Can we give fluid in that case? That is saline resistant. So primary cause we have to treat. We don't have to treat, we don't have to do all these urine chloride in all the patients with metabolic alkalosis also. Because there is loss of fluid is evident. Whenever there is diarrhea, whenever there is vomiting, these are evident. So urine chloride, not necessary to do urine chloride in all the patients. Urine chloride we can do in hyperaldosteronism patients. Or else Cushing syndrome. Cushing syndrome also, this cortisol like have mineralocorticoid action also to some extent. Or else from exogenous steroids, whatever the steroid, apart from dexamethasone, all these steroids will have some part of mineralocorticoid action. So these will cause mineralocorticoid, all these mineralocorticoids, they will cause absorption of sodium along with water with loss of potassium with H plus. So obviously there will be metabolic alkalosis will be. Sir, that is misnomer. There is no role of bicarbonate. Especially we are using. Yes. We are using in all the cases of metabolic acidosis, even with respiratory acidosis. Severe dengue is completely different pathology, sir. Severe dengue in capillary leak syndrome, there is no role of bicarb. We have to go for dialysis. We have to go for CRRT or else lead. The issue is inotropic support for temporary covering of pH only. Ideally, I prefer buffering system in those cases. Physiomax is there. Physiomax, the buffer system in Physiomax, the buffer system in RL is lactate. There is no buffer system is NS. So NS is highly acidic. Buffer system is in RL is lactate. Buffer system in Physiomax is gluconate and acetate. For lactate to convert to bicarb, liver has to be normal. There should not be any shock. No use of RL. But for acetate and gluconate, no need to give bicarbonate. But temporary covering of pH also, we can give bicarbonate. To minimal amount, only 50 milliequivalents, 100 milliequivalents. There is no role of infusion. Infusion only if large amounts is required, especially in salicylate poisoning, high normal anion gap with high, we can't give sodium at a time also, 100 ml in a shot. This will cause fluid overload. Soda bicarbonate is nothing but we are giving sodium. 1 liter of NS has 154 milliequivalents of sodium. 1 liter of soda bicarb has 1000 milliequivalents of sodium. 1 liter of soda bicarb is, that means 100 ml is equivalent to almost 1 liter of NS. This will cause fluid overload. We can't give 100 ml, 200 ml, 300 ml soda bicarb without knowing the heart status, EF status. Heart status we can't give at a shot. We can give infusion slowly. We can't give at a shot. But infusion causes increase in PCO2. This reverse thing will be triggered. So CO2 will be high. We can't give in respiratory acidosis patients, COPD patients. COPD patients, newer drug came, there is injection TAM, tromethamine something is there. This we can prefer. This acts as receptor of H plus, that's it. We can prefer in metabolic acidosis, respiratory acidosis, every case. But this is costly, not necessary in all the cases. For MRE, nice. This will act as just only receptor of H plus. It doesn't have action on CO2, it doesn't have action on sodium overload. Doesn't cause fluid overload. It's available, sir. Pfizer company. This is available.